Up until recently, the approaches that were taken for pediatric patients with ALL was drastically different than younger adults. So patients treated at a pediatric center would typically get a pediatric regimen, which tends to be less myelosuppressive, versus patients even just slightly older would get a more adult regimen, which is a more myelosuppressive regimen. Now with recent data, such as the recently published 10403 data, as well as some other studies, we found that amongst younger adults, so adolescents and young adults typically aged 18 to 40, those patients seem to have improved outcomes as compared to historic controls when they're treated almost like kids, so treated with pediatric-based regimens. I think one of the challenges is how we should treat older adults because we know that these pediatric regimens, they seem to only have a benefit up until age 40 or 50, and after that point the toxicity outweighs the benefit. And so I think one of the approaches in older adults is to look at ways to both improve upon the chemotherapy, but also to use some of our novel agents, such as our antibody therapies and immunotherapies like blinatumomab and inotuzumab to try to minimize the chemotherapy toxicity and also improve the outcomes.